So we're really excited to introduce Shira Wender, who's one of our nurse practitioners in the cath lab, and she's going to be speaking to us about the prevention of contrast-induced nephropathy. I can't speak. Great. Please join us, Shira. Thank you. Thank you.
Okay. Hi, everybody. I'm going to speak today about the prevention of contrast-induced nephropathy. And let's see how this works. Okay, I have no relevant disclosures. The learning objectives for today are to define contrast-induced nephropathy and recognize this as a frequent post-cardiac catheterization complication. The impact of CIN on the clinical outcomes, understanding pathological mechanisms underlying CIN, to identify clinical and peri-procedural risk factors for CIN, evidence-based review of the prevention of CIN, and the post-CIN management and care. What is contrast-induced acute kidney injury? Contrast-induced acute kidney injury is defined as the acute onset of renal injury following intravascular administration of iodinated contrast media in susceptible individuals. So this is the diagnostic criteria. There are varying definitions of CIN in the literature that utilize different metrics to assess acute kidney injury in patients who have undergone radiological studies with contrast media. While all the definitions agree that a patient must have an increase in creatinine after exposure, the absolute and or relative rise of biomarkers and timeline of the kidney function injury is not consistent across the definitions. The most accepted definitions are the three here, Rifle, Atkin, and Kidzygo, and which are used to classify these patients. Currently, these are the criteria used for classifying the AKI based on serum creatinine and urine output. The most commonly used definition is from Kidzygo, which is the Kidney Disease Improving Global Outcomes. They define CIN as a rise in serum creatinine of greater than or equal to 0.5 milligrams, or a 25% increase from the baseline value assessed at 48 hours after a radiological procedure. Serum creatinine generally peaks between 3 to 5 days after exposure, but will return to baseline within 1 to 3 weeks. An alternate definition is proposed by Herjal et al., which classifies CIN according to 3 grades, accounting for both the relative and absolute serum creatinine rise cutoff, which also correlates with long-term adverse outcomes. Here we can see the severity grading system outlined. What is the mechanism of contrast-induced acute kidney injury? Contrast media has a direct cytotoxicity to the nephrons, leading to cellular death and tubular injury. The increased viscosity of the contrast media also alters the renal hemodynamics, leading to intrarenal vasoconstriction, and this contributes to the medullary hypoxia. Contrast media can generate reactive oxygen species and also reduce antioxidant enzyme activity. As the contrast media is filtered and concentrated within the tubules, this increase in viscosity causes obstruction and paired with the release of the reactive oxygen species, resulting in acute tubular injury. As shown here, the combination of the direct cytotoxicity, vasoconstriction, and viscosity can concomitantly contribute to the medullary ischemia and reperfusion injury. What is the impact of CIN on the outcomes? CIN is regarded as a transient event. Up to 80% of the cases, the serum creatinine level will normalize in about 1 to 3 weeks. However, the contrast-induced nephropathy is one of the most frequent complications after cardiovascular procedures with very unfavorable clinical outcomes. Why is this so important? Studies have shown that CIN has a multitude of short-term and long-term adverse events. It is the third leading cause of AKI in hospitalized patients. In-hospital mortality is approximately 5 times higher in patients who suffer CIN compared with the patients receiving contrast media who do not suffer CIN. The mortality rates at 1 and 5 years are approximately 4 times higher. Close to 20% of those who develop CIN suffer persistent worsening renal function after contrast media exposure, and 0.7 to 7% of the patients require renal replacement therapy. So it is important to understand that a direct relationship between CIN and mortality has not been established, but that the onset of CIN is more likely to occur in the presence of severe cardiac injury, which also portends poor prognosis. Sorry. In order to reduce the chance of the CIN occurrence, it is important to review the risk factors and indications for contrast media administration prior to giving the contrast media. In order to prevent CIN, it is our job to identify those at risk. Most factors can be assessed from the clinical history, physical examination, and laboratory investigations. Pre-existent CKD is probably the most important pre-procedural risk factor. CIN risk becomes significant when the baseline serum creatinine is greater than or equal to 1.3 in men and greater or equal to 1.0 in women. So there's a difference between the men and the women, which is about an estimated GFR of less than 60, which defines chronic kidney disease stages 3 to 5. Clinically significant risk factors for CIN include dehydration, hypotension, diabetes, an EF less than 45%, advanced age, anemia, nephrotoxic medications, NSAIDs, aminoglycosides, high-dose loop diuretics, and a large volume of or high osmolality of contrast agent. For all patients referred for contrast media procedures, a CIN risk assessment should be performed. In 2004, Mount Sinai's own Dr. Roxana Moran and colleagues created a simple risk score for prediction of CIN after PCI. Her study examined 8 variables that can be plugged into a calculator. These variables include hypotension with a systolic blood pressure of less than 80 or greater than 1 hour of inotropic support, intra-aortic balloon pump, congestive heart failure class 3 or 4, history of pulmonary edema, chronic kidney disease, diabetes, age greater than 75, anemia, and the volume of contrast. So the sum of these weighted variables provide a total raw score and correlates that score to the risk of PCI-CIN and risk of post-PCI-CIN requiring hemodialysis. Model 1 included only pre-procedural variables in 2004, but a more recent paper in 2021 updated the model to include procedural variables, which include bleeding, no flow or slow flow post-procedure, complex PCI anatomy, which were all identified as significant independent predictors of contrast-associated acute kidney injury. Those are the additional variables. So what can we do to prevent CIN? All patients determined at being at risk for CIN should have their creatinine levels measured between 48 and 72 hours following CM exposure, which we know doesn't happen, but it's a nice thought. Patients should be advised to stop all non-essential nephrotoxic medications. Metformin should preemptively be discontinued, not because this medication will increase the risk of kidney injury, but out of concern about the development of lactic acidosis should severe acute kidney injury occur. The most effective prophylactic intervention is adequate hydration prior to contrast media exposure. Supplementing intravascular volume ensures renal blood flow is maintained and dilutes contrast media. There were several large randomized control trials that have shown that oral N-acetylcysteine, which has both antioxidant and vasodilatory properties, reduces the incidence of CIN. The current guidelines recommend the use of either isoosmolar contrast media or low osmolality contrast media. So minimizing contrast media. The most important precaution is to minimize the amount of contrast media required for the diagnostic accuracy. It is clearly associated with the reduction in contrast in acute kidney injury, the length of stay, and the healthcare system costs. This is one of the few modifiable risk factors we have as healthcare professionals. So some ways we can do this include carefully reviewing the patient's prior angiograms in patients with complex anatomy or prior CABG. This will help to limit angiograms to the projections that best show significant lesions. Reviewing prior chest computed tomography imaging can offer significant information of the patency of the coronaries and the grafts, as well as the presence and location of coronary calcification. Including the patient's creatinine, GFR, and safe contrast limits during the timeouts. We also can use automated injectors, and contrast-saving devices can significantly reduce the volume of contrast delivered to these patients. Using coronary physiology and intracoronary imaging such as FFR and IVUS during the PCI can decrease the number of stents used and reduce the volume of contrast delivered. Being mindful of such practices to lower the contrast use will ultimately improve the patient's safety without compromising quality. So a very interesting study by Ferruzzi et al. Examined the incidence of CIN in patients undergoing catheterization procedures via either the transradial approach or the transfemoral approach. This study showed the incidence of CIN was lower in the radial approach than in the femoral approach. It was 6.6% versus 15.1%. In 2010, the British Columbia Cardiac and Renal studies explored the association between the vascular access site and the onset of new chronic kidney disease in patients undergoing cardiac catheterization. The research found that the radial approach lowered the incidence of CIN after PCI, and this benefit was likely due to the reduction in bleeding complications. So, some take-home points. Because the contrast-induced renal injury leads to high morbidity, prolonged admission, and increased health costs, the goal today is focused on prevention. All clinicians need to be aware of the patient's medical history and use of other medications. A detailed history of risk factors like diabetes, CKD, heart failure, and hypertension is critical. Current interventions are centered on the avoidance of dehydration, avoiding nephrotoxic agents, and minimizing contrast loads. As providers, our clinical needs should be centered around accurate prediction, effective intervention, and rapid prevention of adverse cardiorenal outcomes. Anyone?